Good morning. It is Tuesday, February 8th. I'm Alexis Delcid, and for Jess today, Jess is home on mom duty taking care of a sick kiddo, so hopefully everyone's feeling better in her family soon. Sunny, we hope you feel better soon. In the meantime, welcome to the Morning Medical Update. Thank you for joining us here on Facebook and on YouTube. Coming up today, while the Omicron surge appears to be leveling off, students still need to take COVID precautions when it comes to winter and spring sports. So doctors Tim Beaver, sports cardiologist and medical director of the Adult Endocardiography Lab, will explain the risk of myocarditis, along with the best way to avoid this inflammation of the heart. Dr. David Smith, medical director of youth sports medicine, joins us to talk about new guidelines for young athletes returning to sports after COVID. And Dr. Stephen Stites, our chief medical officer, joins us to let us know the latest with COVID and its impact on our health system. We also want to give you a look at the COVID headlines from around your neighborhood. So here you go. Don't put away the face mask just yet if you're heading to Prairie Village or Roland Park. The Johnson County cities voting to extend their indoor mask mandates through March 16th. Council members say it is important for mask mandates to be consistent to encourage more participation. A vote on implementing a face mask mandate for students in Jackson County schools is on hold for a week. Legislators say they want to hear from parents for and against the plan that would affect districts like Grain Valley, Oak Grove, and Lone Jack. Raytown, Kansas City, and Lee's Summit already have face mask mandates in place. And the city of Miriam is giving away 100 COVID-19 at-home test kits today. You have to live in Miriam and fill out the request form when it goes live on the city's website at 12:30 this afternoon. The test kits are free. So make sure moving forward this morning to send your questions to us on Facebook, YouTube, and the Medical News Network. You can find those links right here on your screen, very easy to do. But first, we want to go to Dr. Dana Hawkinson joining us with our newest numbers this morning. Good morning, Dana.
Hi. Yeah, today, we had a little bit of an increase in our total numbers of active inpatients from yesterday. Again, I think we're looking at the total 7 to 10 day running average. Numbers will be up and down within that. Today we have 80 active infections, 20 in the ICU, 7 on the ventilator, and still 96 in that recovery period. So the active infections have kind of ticked up a little bit. I think we were down to 70 at one point, but hopefully the overall trend continues to be in the right direction.
Dr. Hawkinson, thank you. I think I called you Dana there.
Got a little just call him Hawkeye.
Just
call him Hawkeye. That's what I'm going to call him. Hawk.
So
Hawk. He's been Hawk for 2 years.
He's
Dr.
Hawk from the Hawk Nest.
Yeah.
Dr. Stites, is it too soon to say that this is a trend in the right direction, or can we say this is a trend in the right direction?
Well, let's look at some national data to help with that question. So, we've got a couple of graphs for you. This is the graph, first of all, for the United States. And as you can see, this is throughout the entire pandemic. You can see the first wave in March of 2020 in the summer. And then you can see that second wave in November. And then you can see the Delta wave that occurred kind of in the late summer, early fall. And then you can see the Omicron spike. Now, it's a distinctly different wave, right? Look at how fast it goes up, but then look at how fast it's coming down, which is the experience that has been experienced. This is what's been experienced in other countries, South Africa, Britain, et cetera. But as you watch the fall, look at where it is on the number of new cases. The number of new cases, as we decline on February the 6th, was still higher than at any point in the entire pandemic. So it's not like it's gone away. It's not like Omicron is really just cold. We've also said, if you look down there under the hospitalizations, we've had more hospitalizations than we've ever had at the highest peak. Now, it's starting to fall more rapidly, which we like. But now let's go to the state of Kansas and see the next graph. It looks just like the U.S. graph, right? You could see the different parts of it going up and down, and then you see the really high spike and the rapid fall. But still, the number of new cases is higher than it's ever been. And so that's what we have to remember, that while things are a lot better in terms of the number of new cases, first of all, those number of new cases are only the ones we report in our testing center. They don't record all the ones that are being done at home, and they don't get all the folks who aren't even testing. So most folks think the number of new cases is 2 to 4 times that number. So it's actually still really high. The good news, though, is that Omicron doesn't result in quite the same number of hospitalizations, and we also know that if you get hospitalized, your chance of having to be in the ICU or on a ventilator is it's probably about half as much or about 40% less than what it was in the other waves with either Alpha or Delta or the original strain. So that's good news. We still have a lot of COVID patients. When we sit and we say, okay, things are better, they're better. It's not time to pull off your party hats and the little, what's those little noisemaker things you do and have a big, COVID-free party, because we're not COVID-free. We're COVID better. Right. And we've got room to go before we're COVID-free. I do think we're in the midst of seeing something really good happen. I just don't think it's here yet. And the question you have to ask yourself is, how much protection do you want to give yourself and your family, your loved ones, until things and the community rate of transmission really, really, really drops? And what does it mean to really, really, really drop? And where will it really bottom out? Some of the things we're seeing internationally is does go down. It doesn't go down to zero. It does go down. It won't be as high as a peak, but it's not going to perhaps go down quite as far as we want. So I applaud those folks who are still trying to wear masks in indoor public spaces, because I think they are protecting each other and taking care of each other and helping us get to the other side of this wave. And we all want to get there really fast, and we want to feel comfortable when you're eating outside or eating in restaurants and things like that again. And I think we're getting there. I do. I think the time's coming, but I don't think the time. Hawkeye is not here yet.
No, it's not here. I would totally agree with you. We know that the cases occur. We have been saying since the data from the vaccines, we don't know that cases are the best bellwether, but more it's hospitalizations. And we know those hospitalizations follow those cases by 7 days to 14 days. We know deaths, though, are still increasing, and that's because deaths do follow those hospitalizations as well. Things are moving in the right direction, just like you said, Steve, but I think we still need to take those precautions, especially with the cold weather, especially knowing that it is still prevalent out there quite a bit. So.
And Hawkeye, the other interesting thing is there's an article from Cutter in the New England Journal of Medicine last week, looking at the impact of getting sick and how long you really do keep some host immunity against severe disease. Yeah. Also, more information coming out about vaccines, showing again the impact they have against severe disease. So both of those pieces of information, I think, are good news. Yeah. But man, it sure is a lot safer to be vaccinated than it is to have the disease.
That's the key, is the safety of that, and the safety does occur within those vaccinated populations, because we know you are less at risk of long haul. You are less at risk of those the blood clots. You are less at risk, especially in those pregnant women. There is a new CDC or NIH study showing the complications that do occur at such a higher frequency in those pregnant women, both for themselves and their babies when they do get coronavirus. So I think it is important to continue to tout the message that these vaccines are the safest thing to do. And we know, luckily as well, that the current vaccines, even with some of the antibody responses, may not be as good against new variants, but we know that you do produce antibodies towards variants that you have not even seen if you are up to date with your vaccine, meaning you are fully vaccinated with those 2 doses and you have that 3rd booster dose as well. But we also, the importance of knowing that those T-cell responses, which really provide that protection against hospitalization and severe disease, also occur and are conserved in those people with vaccination, or people who've had infection and vaccination as well, because Omicron will not be the last variant. We know that other variants will occur. So I think it is important, just as you said, to keep yourself individually, but also your bubble or your family safe. And the best and safest way to do that is through vaccination.
It's funny, I just say, I think that people still think that, earlier in the pandemic when we didn't know a lot, right? Let's be honest. So the plane we were building was probably a skeleton. It looked like one of those things from Kitty Hawk that kept crashing all the time, and you're trying to pedal a little bit faster you go. Now we're probably flying a little better plane, but it doesn't mean we're not still trying to build it and make it better. But originally there was a whole community-wide shutdown, et cetera, and everything was closed down because the forecast were this terrible wave of virus coming at us, and that had been experienced in New York City and other places. And we didn't, and that didn't really, it was bad here, but it didn't materialize like that. And partly was because we had all the public health measures in place, and so I think we were better off. But I think people have to separate from that sort of shutdown to saying now we want to keep schools and businesses open. The best way to do that is to stay safe and wear a mask in public spaces where you're indoors, and that helps make sure the virus doesn't spread so much. And then the schools can stay open because kids need to be in schools. Businesses can stay open and you keep things going. Otherwise, we run into crunch time where we don't have enough people to work, and that's what we see in the businesses that can't stay open, or now restaurants aren't always open because they don't have people to work, or schools can't keep kids in school because they have too many kids or teachers out. So I think while you're still in that height of that curve, and remember, it's better, but it's not good, is to keep doing it.
Until you start to see that trend translate into the hospital. When you talk to healthcare workers, is there a delay between good news and positive news out in public?
There is, and so our healthcare workers are still pretty beat up, right?
Mm-hmm.
They're tired because you think about it. We have had 2 weeks ago, 224 COVID patients in our hospital. And 2 years ago, how many COVID positive patients did we have right now?
None.
0, right? We had none.
Right.
Right, we have an 800-bed hospital, and back then we had 750 beds or whatever, and so then we had none. And now what got displaced for those 224 patients? What are we not taking care of? Because we were full then, we're full now. What is it we're not taking care of? And the answer is we're not taking care of you, right? Because if you happens to be in a small town with a critical diagnosis, if you have a heart attack and you're in some place where that they can't really get, who takes care of that person when we're all full? And the reality is that we don't give as good a care because we have 224 patients who don't really need to be here, right? They don't need to be here. They need to be here because they're sick. I give you that. But if we follow the rules of infection control and we all get vaccinated and we stay up with their boosters, then you know what? Those numbers would drop down to about 24 or 30. Mm-hmm. You know what? Bring it on. But that's the problem, is that people want to believe that Omicron is oh my cold. But oh my gosh, our folks will tell you it ain't a cold when you're up there in the ICU. I mean, I had a patient hospitalized last week I was rounding on, and she was at day 13 after being hospitalized for COVID. And all of a sudden, boom, she had the flash inflammatory state. Her lungs got in trouble. We had to do steroids and all that stuff again. And it's a struggle when you take people who are already sick, those are 65, those are immunocompromised, and you bring them in the hospital and you expect them all to do well with COVID because they don't. And that's why, Hawkeye, we continue to see deaths. And I think the take-home message is that there are better times a coming, and they're not that far because you can watch the numbers drop, but don't be deluded into thinking the Omicron is really not that bad, because it can be really bad if you're the one, Hawk.
Yeah, absolutely. We still see deaths, just like you talked about. We still see severe disease. The vast majority of those people who are unvaccinated or not up to date with their vaccine, and that also includes those comorbidities, age, obesity, diabetes, lung disease, chronic kidney disease, immunosuppressed patients as well. And so when you do get vaccinated, when you do wear a mask, that impacts your community, because there are so many people out there that you don't even know about who may be on immunosuppressive drugs, who may have some other conditions that lend themselves to being at higher risk of infection, even though they are probably doing everything they can to try and stay safe, being up to date with vaccination, wearing masks. It continues to be not just an I and me thing, but it is a community-wide thing, in the fact that this is so transmissible, and you can spread it 1 to 2, maybe even 3 days prior to knowing that you have symptoms.
And I just say, I'm a silly fan. I love Star Trek. I always say live long and
do?
prosper. And all that. I know it's a hard thing to believe. I do love that show. But we really do want you to live long.
Right.
We really do want you to prosper. And you have to step back and say, how do I do that? Well, what's going to get me to the other side of this? And it's the same thing we've always said. The rules of infection control keep you safe and travel with you wherever you go, even into this moment and every day going forward. And if you're just willing to follow them, you're going to be okay, and we're all going to be okay. But we got to get through this, and the way we get through it is to follow the rules. You follow the rules, things get better. If you follow the rules, we can all still take care of each other, and we can take care of all those patients who need us with time-sensitive diagnoses. So let's just try and help each other a little longer. Again, I think some good times are coming. And there's another variant that hits out there, but when we get through this and we get into mid-March and April, I think, things can be pretty good. I'm looking for the Royals. I'm telling those guys, get that dadgum labor dispute figured out so we can get back to the baseball park.
Speaking of sports, we also
Yeah.
have a really good topic this afternoon that we're going to, or this morning that we're going to dive into about COVID and youth sports. There are parents who have anxiety about their teenagers playing. I know some of us have teens at home that are having the same questions. First, want to open it up to reporters, though, to see if there are any reporters on the line. And I do have a question from KMBZ. Rebecca wants to talk, or would like if you doctors would talk a little bit about the efforts to require pharmacies to fill ivermectin. No, that's a hot topic. You have a lot to say about that.
Hydroxychloroquine
Yeah.
and all that. Yeah, so we talked a little bit about this last week, and it has to do with whether or not physicians and pharmacists can do off-label use. So that when a drug's approved by the FDA, it's approved for an indication. It's not just the drug's approved, but the way it gets approved is there are trials that demonstrate efficacy of that drug for that disease. And so then it's approved. Once the drug's approved, it's approved. It's approved for use in. Then what happens is you can go right for that drug, and I can do off-label use, meaning the label is for a certain purpose, but then I can go ahead and write for it with a different purpose. And I've done that in my career, right? Because I do cystic fibrosis. And in the 90s, there were very few CF drugs out there. There were very few pulmonary hypertension drugs out there. And so we would take some drugs like colistin or tobramycin or gentamicin that were meant to be IV. We'd mix them up into a solution. We'd have people inhale them. We did that on the basis of some small clinical trials. No big studies had been published yet. But the small trials did look like, and there was good scientific evidence. There was open scientific debate at meetings, and then people would start to do it. And then you would work with pharmacists to try and figure out what the right dose was. But there was a check and balance system in that. The check and balance is this. I would sit down with the patient and say, listen, this drug is not indicated for this use. But here's our choices. Here's why we think it works. What do you think? Are you interested? And here's some proof that it works. And then we would sit down and we would ask the pharmacist, hey, are you comfortable mixing this up? What do you think? And they'd give us some tips, and we'd work back and forth together about the dose, et cetera. And we would use those drugs like that, and I think they help patients. And then years later, back in 1999, I think, there was tobramycin for inhalation, which is a drug that you could inhale, an antibiotic that actually had been in through a randomized study and been trialed, now was FDA approved exactly for that indication, which is the first time we'd had that. So now let's flash forward to the conversation what's going on with hydroxychloroquine and ivermectin. First of all, there's just no really good evidence, Hawkeye, and I'm going to turn to you in a minute.
Yeah.
You can review that evidence.
Yeah.
But there really isn't great evidence that it works. There are people who want to say, look, I've tried it in my own practice. That's not a study. That's you trying it in your practice, and that is not the same thing. When we were doing colistin or gentamicin for inhalation, there were studies that people had designed and looked at it. But that's not the case. There really isn't a debate about whether or not ivermectin and hydroxychloroquine either prevent or improve, because there are a lot of big studies that looked at it and said, hey, you know what, this really doesn't work very well. So then what happens is that a physician may say, well, look, I still think that there's some proof in it, so I'm going to go ahead and write for that off-label use of it, and I'm going to tell the patient that, and then the patient has to go get that filled by a pharmacist. And the pharmacist can look at that and decide, well, this doesn't feel safe to me. I think it interacts. The dosing's not right. The evidence is not there. I'm not going to fill that. Because the pharmacists are the experts at filling and dispensing drugs. Physicians are the experts at trying to interpret the data and prescribe the medications. And that is the check and balance system. And then the pharmacists and the physicians share the risk for that. And the patients, if you're going to go off-label, oftentimes have to do what's called, you have to get sometimes you even have to get a clinical trial indication or what's called an IND to do it, and then you have to have informed consent. It's a big deal, right? It's not something you just run out and do. My problem with the hydroxychloroquine and the ivermectin isn't that people should be able to give off-label use, because I'm okay with giving off-label use. I am. I mean, we said that all the time. I've done it. We all do it, because when a drug's approved, it's approved, and you can go off-label. The problem is when you then shift the burden of proof over to away from the physician, the pharmacist, the burden of responsibility, the risk. And you say, okay, now if somebody writes this, you have to do it. And if a patient asks for it, you have to give it to them. No, I don't. That's just wrong. Your kid walks up and says, Mom, Dad, I want a cookie. You have to give it to me. That kid doesn't know if it's good for him or not, right? That could be the worst thing in the world. And instead you say, no, you see, you're going to have dinner. You're not going to eat right now. And you're not going to, and you know, as a parent, you have to exercise the responsibility of making the right decisions. And as a physician and a pharmacist, these are people highly trained in the field who have spent years of their life trying to get into this and often are highly specialized in the prescription of it. Like Hawkeye is highly specialized in infectious disease. I think we ought to give those drugs which are being treated for infectious disease that we don't really know about, we ought to consult with our ID colleagues and say, guys, is this a good idea? Rick Coldry, our pharmacy guys, hey, are you comfortable prescribing this? Don't give it to somebody who doesn't really practice in this sphere and ask them to do it. And most certainly don't give the responsibility to a patient who doesn't really understand the question to ask. They may have done some internet research. That is not the same thing. It's been in years of your life training and looking at the information critically.
You had described pharmacists as in a previous morning medical update as the last line of defense.
They're the last line of defense for making sure you've done the right thing.
Right.
Because sometimes I've written scripts wrong. I got a call from our pharmacy in the United States. Hey, blockhead, what the heck are you doing here? And I'm like, dang. Thanks for catching that. No, I said thank you very much for doing that. We have these pharmacists who work with us on our CF team because if we have to use a lot of high-risk medications or a sick patient population, transplant something, and they're like, what are you doing here? Or I ask them, I said, listen, can you help me research this drug and let's look at the evidence together? Lindsay and Michelle, we should get them down here. They tell you how often I'm wrong and make sure I don't get something all screwed up. So they do a great job, Hawkeye. You can't let that last line of defense go.
Yeah, no, I think that's right. They do, that is their job. They do double and triple check things when we prescribe, make sure there's no interactions, make sure there's other quality controls that need to occur, and so I think that is important. We try to catch everything, and we try to be detail-oriented, but medicine is complex. It isn't just a simple thing as writing a prescription for a drug you think works. We do see this all the time with antibiotics prescribed for sinus infections, which we know 80% or more are viral and things of that nature. To your point, Steve, and we mentioned this before, you were using that drug off-label, but it was still against bacterial pathogens, which we knew that antibiotic works against. You weren't using it against influenza or a fungal infection or RSV. You were using it against a bacteria, and so that's the thing here as well. And the issue is really, do these drugs work? It continues to be really based upon opinion that they do work rather than actual scientific fact and evidence. And we know that a lot of the evidence that has been brought forward has been retracted. We know that there were significant caveats to a lot of the published materials. A lot of those data have been retracted by the journals. The authors have been reprimanded. We know that there were disclosures that were not made. For instance, some of the data that came out of Argentina, we know some of those investigators were actually part of the drug company that sells ivermectin. So I think it is very important. And just understand, we start at that evidence base, and we take a lot of guidance from our main bodies. Some of those bodies include the NIH, the CDC, the FDA, and the World Health Organization. We know right now a lot of these drugs are not recommended for use for treatment or prevention of COVID-19 either. So we really continue to stick with the evidence-based aspect of that rather than the opinion-based
What I would say, Alexis, is just, you don't want me to fix your car. Yep. You don't want me to review your personal finances. You don't want me to try and repair your house or paint your house. I'm not very good at that stuff. I'm pretty good at the area that I practice in, so I really try to stay in my lane and say, here's what I know. And I know medicine relatively well. And what I would at least pulmonary medicine, what I would say to you is that you want the people who know prescribing you the stuff that they understand and have studied that in a time of great crisis. And what you don't want to do is respond to panic and fear, because panic and fear don't cure you.
And I think in that vein as well, Steve, and it's not only going from being a mechanic or financial services, even in the specialty of medicine, I prescribe antibiotics. I'm not an expert in pain management and pain medicine. I'm not an expert in those endocrine medicines. I'm not an expert in cardiology. You would not want to come to me if you had a heart condition or something complicated like that. And so that's why we have the experts. Even in medicine, we have those subspecialties because they have trained in it. They understand all of those ins and outs, all of those details of those medicines.
And what I would say is that, I know you probably want to get a word in because we're going here.
Right.
We have two other experts in-house right now for different things. So.
Yeah. You don't want me putting you to sleep in the operating room. You don't want me doing your fracture in your leg.
Right.
But if you got some lung diseases, bring it on. If you get some infectious infectious disease, let's call Hawkeye. We can help with that. And I think that's what it means, stand in your lane and trying to do the right thing for your patients is. And again, the medicine is a system of checks and balances. When you take out those and you do it for specific medications that, again, we can all do off-label use, but you got to do it right. There's a process and a way to do it to make sure the patients are still protected. To suddenly give 2 drugs certain protection by the Senate on the basis of, I'm not sure where that evidence comes from or the information. That just doesn't feel very good to me. And again, I'm somebody who does off-label use, but I don't do it like that.
I do think it would be fun to have Dr. Stites come help me with my house repairs after work today.
Well, no,
see what happens.
If you want a bigger bill after that, I can help
then you can do that?
Yeah, that's not what you want.
You've been talking, both of you have been talking about there are various specialties in medicine, and we have 2 other pros on the show this morning to talk about myocarditis and teenage boys. If you're the parent of a teenage boy, you've heard about this, you've talked about this, and some parents of teenagers who are vaccinated have been worried about the possibility of myocarditis, which is an inflammation of the heart. But recent data shows the risk of myocarditis from the vaccine is extremely rare. It also shows the risk of myocarditis from COVID, though, is much, much greater. So joining us this morning to talk about that and what teenagers and parents like us need to do to protect our kids and return to sports after COVID are Dr. Tim Beaver and Dr. David Smith. Good morning to you both. Want to start with Dr. Beaver. Specific to young athletes, how does the risk of vaccine-associated myocarditis compare to the risk of your heart from catching COVID?
I think you guys detailed it pretty well at the beginning of the show, and with the comments that you've made is that, first of all, myocarditis from any cause is pretty rare. It's just to give people a base, right? We see myocarditis every year, and it's a inflammation of the heart that young men are more prone to. They have more active immune systems, and so post-viral myocarditis occurs with other viruses, not just the COVID virus. And so it is pretty rare. The vaccine-associated myocarditis is rare as well. There's been numbers thrown out there. I think the highest risk age group has been shown to be between 12 and 17 in the current boat and the plane we're living in, as Steve put it. And that's 50 per somewhere around million doses of vaccine. The risk of myocarditis from the COVID virus itself is about 100-fold that. They're both still really rare entities. So most of the people that present with myocarditis from the kid standpoint and teenage group have, they present with symptoms and they tend to do very well, and on follow-up testing, almost all of them resolve. So there hasn't been long-term sequelae. The worry about myocarditis from a general community standpoint is that when it goes unchecked or unnoticed, that you can eventually have complications where your heart function is down more permanently and have dysfunction from that and have your lifestyle affected.
I want to bring in Dr. David Smith, who heads our youth sports program. Dr. Smith, you're on the Sports Medicine Advisory Committee of the Kansas State High School Athletic Association, and your committee just updated its guidelines for student athletes who are returning to play a sport after COVID. Can you break down those new guidelines for us?
Sure. Thank you, Alexis. First of all, I'm humbled to be on this program with experts. And I'd say I'm sitting here thinking, what am I expert at? Well, for 32 plus years, I've worked with athletes at all levels, Olympic level, pro level, high school level, lower than that, recreational, and those wannabe athletes. And when I think through it, these guidelines were done with a lot of thought. Literally 2-3 weeks ago, what we were seeing with the resurgence of COVID was that we were knocking out more athletes from their sport. Yet we had these guidelines set up back in September to try to get them back to sport. The problem was we said they have to see a provider first. Well, the reality is a lot of these student athletes don't have a provider. And when they don't have a provider, or the provider is so busy they can't get them in the office, urgent cares are packed, ERs are packed, and obviously we'd never want an athlete going to the emergency room to be cleared for COVID. We had to start thinking about how we're going to help these young athletes do the right thing, not just get them back to sport. And that's true of any athlete coming back from any problem, whether it be an injury or an illness. So we sat down as a committee, and this committee is a It's a great committee. It's across the state of Kansas. We have athletic trainers, physicians, a chiropractor, a psychologist, administrators at schools. We have a representative from the Kansas State High School Athletic Association. And we work really hard as a team to try to put together something that's reasonable. And what we came up with was interesting. We were about ready to put it online with the Kansas State High School Athletic Association. Well, the AAP, the American Academy of Pediatrics, and the AMSSM, the American Medical Society for Sports Medicine, in conjunction with the National Federation of High School, put together guidelines that looked very much like ours. And what those guidelines are is, okay, we need to break it down a little bit. Obviously, there's going to be athletes participating that have no symptoms or very mild symptoms. There's going to be some that have moderate symptoms. There's going to be some that are very, very sick and in the hospital from it. And we felt like, given the data that we know right now, that it is okay to break it down and say those that have very mild symptoms maybe don't have to see a provider, but if they have clinical concern, they ought to go in and see their provider, their physician, nurse practitioner, PA. If they don't, they should stay home, though. If they are asymptomatic and they test positive or they're minimally symptomatic, day one is the date of the test or the date of the first symptoms. And we say you ought to stay home at least 3 to 5 days. Stay away from people so you don't spread it. You know, if you want to take a walk, that's okay, but you really need to just let your body relax and get better. And after that, you can start walking on your own, and if you still feel good, then we have a graded program, 5 stages that actually can span over 7 days, where we will gradually increase your activity. Stage 1 lasts a couple days. It's pushing the heart and the lungs a little bit, but only up to 15 minutes of light exercise with a maximum heart rate, at 70% of maximum heart rate is a guideline we've given. And we see how they feel. If they feel good, we can advance it to the next stage, and that's a little harder exercise, but still limited duration. If they still feel good, we advance to stage 2. That stage is longer duration, no heavy resistance training, which puts more load on the heart. And that stage can be a day. And if they feel very well with that, we'll advance them to stage 3. Stage 3 is what I call the critical stage. This is the one where we add duration and intensity. So up to 45 minutes of exercise at a maximum or 80% of maximum heart rate. We can add some light resistance training. We can do more skill type running, maybe some drills, but kind of keep track of them for that stage. And then the next stage advances them to a full practice. And ideally, we like this under the guidance of an expert. You know, our athletic trainers that are on the field are experts in knowing how to monitor athletes and their symptoms. And if the athlete is honest, which is a point that we put at the top of these guidelines, that we trust that they're going to be truthful with the healthcare information, and they feel good, then we advance them to the final stage, which is game day, basically. Now, these guidelines are guidelines. We don't have hard and fast research on them. Tim Beaver just mentioned that COVID is not the only virus that we worry about when it comes to myocarditis. People may not remember, I'm old enough to remember, we had a swimmer die at University of Kansas. A competitive swimmer died. I remember clearly the report. I was not working at UKU at the time. And he died. And the reality was he had viral myocarditis. Well, that is 25 years before COVID existed. Mm-hmm. We know full well over my entire career that there's other viruses that can affect the heart. So we feel like strongly through my career, we've said, gradually resume your sport, adding demand to that exercise. And as long as you feel well, keep bumping it up. And if you feel good, you can be back on the field. So these guidelines, the basic things are, the mild don't have to see a provider. Some still debate that. The American Academy of Pediatrics does state in their guidelines they ought to have at least a phone call, a telehealth visit, or an in-person. We, as an organization in Kansas, as well as our AMSSM, has said that they don't necessarily have to do that. That has helped tremendously because some of these young athletes now are willing to say, yeah, okay, at least I don't have to go see the doctor, but I'll follow these guidelines. And they're guidelines. They're not mandatory legislative rules.
Dr. Beaver has been talking about his research on COVID on the athletic heart. And I've heard that the athletic heart, is there an inherent risk that's more for a child with an athletic heart? Or what do you mean by that?
Well, to clarify, the athletic heart, just you're looking at the morphologic changes that putting yourself through systematic training affect the heart. So the athletic heart is just that, it's different for every athlete depending on the sport they participate in. So I don't know that the inherent risk is higher for an athlete. It's not, actually. We've shown that. the studies over the last 2 years, we've had over 800 professional athletes in a registry. We've had over 3,000 collegiate athletes that we contributed our data to from the University of Kansas, to showing the risk for these athletes getting COVID is very low for complications. And so that's where the return to play guidelines have become more conservative. If they have cardiopulmonary symptoms, especially in their return to play algorithm, as Dr. Smith said in that stage 3, or they have moderate or more symptoms during their illness, and they're going to put themselves at risk for being a high competitive athlete, then they do undergo testing. But if they have milder symptoms or they're asymptomatic, entering that return to play protocol and monitoring for symptoms is really the key there.
And Alexis, I might add too, the symptoms that we call the big red flags would be, and Dr. Beaver, you correct me if I'm wrong, chest pain, shortness of breath greater than, feeling a little out of shape, palpitations, feeling like your heart's skipping a beat, pre-syncope, which would be near passing out, or syncope, passing out. Obviously, those would be huge red flags. And again, if you're being monitored by an athletic trainer, they can see that on the field. Even a coach can recognize that. But athletes they're driven. They want to get back out on the field. And I have all my career said, you have to be honest with us. I'm going to be honest with you 100% of the time. If you're honest with me and I'm honest with you, we're going to get through this. Back in the fall, we just didn't have a lot of problems with COVID in our fall sports. And then the resurgence hit. And the winter sports are inside, much greater risk. And the observation I have is I attend wrestling matches and high school basketball, and I watch on TV the Olympics now, and unfortunately the NFL playoffs, it didn't go our way. But you see the improper use of masking, social indistancing, I call it. I mean, they're just not doing the right things. Until last night, I watched Nathan Chen in his short program. He's the only athlete I've seen so far that masked properly. He had an N95. He came out, they introduced him, he had double loop over the head, sealed up. He waved to everybody. He took it off. He did throw it aside. I don't know where it went when it got thrown aside. Then he warmed up, came back, put the mask on. When he went out to compete, took it off, did his performance, put it back for the kiss and cry area. And I thought, good for you, Nathan. You're demonstrating what should be done.
He's a role model.
He's a
all
role
across
model.
The board,
the problem
right?
is when I watch these, I hate to say it, these coaches, the chin strap is common with coaches. I watched the high school game where 50% of the players on the bench had masks on. That 50% were worn improperly, and the coaches on both teams under the chin the entire game. I'm proud of our KU students up in the stands. Of all the venues that I watch when I watch TV, our KU students are the only ones with their masks most of the time properly worn.
Really, that's what you've
Can
noticed?
we do a shout out, because I think that is a really important point.
Dr. Gerard said that. You better mask up and
Or
do
you're
it
not
right,
gonna
or we're
go.
going to cut the fans out.
And I think that's right, because Laura, there's still a positivity rate of 20%. Douglas County still has a lot of positive cases. We're still at a higher peak than we've ever been prior to this, right? Even though the numbers are down a lot, which is great, we're still high. And you don't want to take out. And the truth is, KU as a campus is doing well. They've done well the whole time because they've taken this seriously and they've done a great job. So I applaud Allen Fieldhouse. I am so proud of that.
Yeah, it's not perfect, but
No,
I'll
it's
tell you,
not.
look at Arrowhead Stadium, you go, ooh, besides the loss,
That
my
gives you a
lands.
headache, right.
It gives me a headache, yeah. But you know what? Proper use. We know the masks are not perfect. Everybody knows that. But they can be helpful if worn like Nathan Chen. So I'm going to use the Nathan Chen story from here on out. Is you guys, they're vaccinated. They're getting tested twice a day. If they get positive, they go in isolation in a hotel in China, and they don't compete. And we already had that happen with a bobsled athlete.
And just to say,
Should
you know,
be a
he wants that
hashtag, wear it
gold
like
medal.
Nathan Chen.
There you
Yeah,
go.
Yes.
wear it like
Well,
Nathan
he
Chen,
wants the gold
not
medal,
on the
Chen.
chin.
That's pretty
Steve,
good.
that's your
Not on the
thing.
chin,
Yeah,
wear it like
that's your
Chen.
thing.
Yeah.
Yeah.
Well, you know, he wants to compete. He doesn't want to be
Absolutely.
taken out. So what's he going to do? He's going to follow the rules of infection control. Because
Right.
what do? They keep him safe.
Right. He's following Dr. Stites.
Yeah, I
and
don't think
Dr.
he's following me,
Hawkinson,
but
what you
he's
guys say.
done a good job.
So what happens then in the rare case that you do have a teenager who gets myocarditis? Are they able to get back and compete that season? How do you handle that? Dr. Smith, Dr. Beaver, yeah.
I mean, generally the recommendation for myocarditis in general is the athlete is pretty much out of competition for 3 months of observation to, treat their inflammation and make sure they're safe. As he described, the swimmer, when you have an active inflammation at your heart, your arrhythmia risk goes up. So that's why that they're put in a cool-off period for at least 3 months, monitored. They're re-imaged at the end of that. A lot of times we put them on the treadmill to make sure they're not having arrhythmias. We put ambulatory monitors on them to make sure they're not having arrhythmias and look for their heart function to recover. And that's sort of the return to play if you truly have myocarditis. As a sports cardiologist, that's the algorithm we would follow for at least 3 months, sometimes it's 6.
And that's consistent in all the algorithms, whether it's the Academy of Pediatrics or our sports medicine organization or our state of Kansas CASHA recommendations, because that's the person Dr. Beaver or a pediatric cardiologist is going to see. That's not someone I would clear. I think that we work in conjunction with our specialists, but we can't load up Dr. Beaver with everybody that has the mild symptoms, and that was the point of these return to play. The observation of athletes coming back with a functional progression of a higher demand on the heart and lungs is very, very important. I mean, Dr. Beaver, you know that's a test, basically. And that test can be better than just an EKG, although an EKG would be part of the testing that we would do. So it's the return to play functional progression is so, so important.
And it's a complex layer, yes?
For those people that, do develop symptoms or have moderate more symptoms during their illness, right, they get what we call the triple screen, which is an EKG, an echocardiogram, which is an ultrasound of the heart, and then we look for tests. We do a blood test to look for troponin, to look for heart damage, just like we would someone that potentially were worried having a heart attack. So there is a screening algorithm that we've used throughout COVID for our collegiate and professional athletes, as well as other people that have moderate or more symptoms. And so I think these guidelines he's talking about just sort of make sense. And they also, if you think about it, if you're a person in the community, even if you're not a teenager, you're an adult that wants to get back being active, or, athletes aren't isolated to being professionals or collegiate athletes. People are athletes in their adult life, whether they run 5Ks, run marathons, do triathlons, and having it make sense that you actually put yourself into a little bit of an algorithm and monitor your symptoms as an adult so that you can make sure you're safe getting back to being active is important as well.
We are getting a lot of community questions on this topic and in general on COVID, so we want to get to some of those because my phone is blowing up here. We'll start with Rebecca Anderson, who has a question for the doctors. Can you talk about the risk of reinfection with Omicron? Our friends had it a month ago. We were going to see them for my hub's birthday. We will test, but we want to make sure we're still in the safe window. So what's the safe window after Omicron?
Yeah, I would certainly say, Omicron, especially in our community, continues to be the vast majority, 99% or more of the variant that is circulating right now. If you were infected a month ago, you are now going to be making specific antibodies to Omicron. I think it's pretty safe. Reinfection is going to be extremely rare. So I think you should be able to do that.
I think you're safe, and if you've been vaccinated, you're especially safe. And I think the information around vaccination is beginning to. We're learning more and more as we build this airplane. In this case, it's the vaccine plane. We can call it the jet vax. Something like that. That we're beginning to see more clear information. So, for example, in the people who are really highly immunocompromised, it's really not a series of 2 shots, a series of 3 shots, followed by another shot. Now, CDC recommended last week 3 months later, not 5 or 6 months later. So if you're somebody who's really immunocompromised, you've had an organ transplant, chemotherapy, et cetera, you're going to get a series of 4 shots over about 6 months, which is a different recommendation than for those of us who are relatively healthy. There's also some talk, it'd be interesting to see what Dr. Beaver thinks or Dr. Smith, about taking the interval and going from a 3 or 4 week between the first and second shots to 8 weeks to lower some of the risks of myocarditis and side effects. I don't know, Hawk, what you think about that. So we're continuing to evolve around the importance of how we vaccine, but somebody in the situation you've described is pretty safe. But what do you think about those changes about vaccine policies?
You mean in general?
Yeah, or just that one about that whole thing about do we expand the interval from 4 weeks to 8 weeks between the first and second shot?
Yeah, I think there's pretty good data to support the fact of expanding the first to second dose further than that 3 or 4 weeks. Again, if you remember, when the vaccines were being tested, we wanted to get those into arms. We knew they were safe. We wanted to see what is going to be efficacious in preventing mostly hospitalization, but we also found that it was efficacious in preventing infection in that beginning part. So they were doing it in that shortest time period available. But I think if you can expand that timing from first to second dose, you are only going to improve that immune response after that second dose. And then, of course, if you can wait those 5 or 6 months really to that third dose, that is when you continue to have immune response evolution. So then when you do get that third booster dose, it's going to be fairly optimal.
Isaac has a question for our guests. Isaac writes, I've read on remarks on occasion from Peter McCullough, a cardiologist at Baylor. I haven't heard of Dr. McCullough. Have you guys heard of him?
Yes.
Okay, who said, Dr. McCullough said that children shouldn't be vaccinated because of the risk of myocarditis. What is your response to that, doctor?
I think the American College of Cardiology has a whole group of people that are actively researching all of the information that's come out about vaccinations and COVID within and the risk of myocarditis, and looked at the data, and the American College of Cardiology has come out and said the risk of COVID is still higher from a cardiovascular complication standpoint than the risk of myocarditis with the vaccine. And the information that the majority of the people it's a self-limited problem that they are improving and coming back to normal. So again, that's the data that we have so far. But each one of us, we talked about our super subspecialty societies, and our societies are doing that. They're actively taking the role of looking at that data to try to help the general cardiology community with relation to that, and the community overall, to look at the safety of vaccination and the risk of myocarditis. And they've released a preliminary statement that supported that, because there's still a more higher complication rate with the virus itself.
Jean has a question. Jean has heard that the booster does little good to those 50 to 65, but is valuable for those over 65. Have you heard that?
Yeah,
that
so
it doesn't
well,
do...
actually, let's correct that a little bit.
Okay.
So there is some stuff coming out about the number of boosters you need if you're over 65 versus if you're younger, with the idea that the younger you are, the less critical the booster is, the older you are, the more critical the booster is. So I'd be a little careful with having a broad sweeping statement about those 50 to 65 and say, and again, this is where you work with your especially your primary care doc and say, what risk category are you in because of your other diseases that are there?
Right.
So I'm 62, have a history of prostate cancer. So you know what? I want my booster. We have a team. Let's go. And I work in a high risk environment in healthcare, so I'm gonna want a booster. But the evidence is really clear that over 65, there's a huge effect for boosters as far as hospitalization and death. But the reality is there is still an effect. It's just that the effect begins to lessen the younger you are. And so then it's just how many people need boosters. And I think that this is one of the situations where, Hawkeye, we are building the airplane while we fly it. Mm-hmm. And as we learn more about this, we'll probably refine the recommendations around booster frequency, et cetera, just as we have now for organ transplant patients and those who are most immunocompromised. Before it was like, okay, you're going to get one shot a month apart. Well, now you're going to get 3 shots each a month apart. Then it was going to be, you were going to wait 5 months for a booster. Now it's 3 months for a booster. It doesn't mean that people were wrong or they didn't know what they were doing. I really hate that part of the debate.
Yeah.
Right. That's just, it's like, no, the more you learn, the smarter you are. And the more we've learned, the smarter we are, and we refine things. So, Hawk, that's all.
Yeah, and what was the wording on that question exactly?
It said that
50
if
to 65,
it doesn't
you
work,
don't need a booster.
does little.
Jean says it does little good to those 50 to 65. That's a small window, 50 to 65.
Yeah, and I'd just kind of like to clarify, what does little good mean? I think this also goes back to one of our earlier questions, and I think it continues to be maybe 2 are needed if you do expand that time frame from the first dose to that second dose, and whether it's 12 weeks out or 16 weeks. But I think the important thing here is I think that booster is important, and I don't believe it does little. I think the important thing there is that you have that time frame, really that 5 to 6 months in that original recommendation, where your immune system is evolving. And then when you give that third dose after that 5 or 6 months after that second, that's when you really do have that boost. And you can see, we can identify neutralizing antibodies to Omicron after that third dose, even though your body has never seen Omicron. So I think that's the important thing here, is you have to consider that time frame between that second and third dose. But overall, I would agree with Dr. Stites. In general, that third dose is really going to help, and it's really more of a function of that time from that second to that third dose.
This one might be good for Dr. Smith and Dr. Beaver. Taylor wants to know, why are some countries across the world choosing to not recommend vaccination for younger men, while the United States is promoting vaccination for young men? And
Yeah, I can't comment on that. Probably Dr.
Or
Beaver
F.
watches that research. I know there's always studies in different areas of the world that are analyzed differently. And, you know, I have to admit, I trust Dr. Beaver, the American College of Cardiology, and much more than I would some of the European societies. I'll just make that a statement.
We seem to be encouraging everyone to get vaccinated, or young
Yeah.
boys,
Dr. Beaver
teenagers.
Yeah, I
says.
wanna see what he
Tim, what do you
says.
think?
Yeah, no, I don't really have knowledge of the data or that some countries are leaving younger people out. That's not something that's with me. I think you guys have someone on later this week that is on a vaccination committee, maybe knows a little bit more about sort of the recommendations that are outside of the United States, but I don't have knowledge of that or the rationale behind it. on
Yeah, I
the
think some
tip of my
countries
tongue.
don't have the same supply of
I think that's
vaccine.
a
I
lot.
think that
That
had
could
a lot
be.
to do
That's
with
a good
it.
point.
More
And the
at-risk
second thing they said,
populations.
well, gosh, guys had a little bit more myocarditis. Maybe we shouldn't give it to them. Girls don't seem to do it, or women don't seem to do it. So we're saying we don't have as much vaccine. Let's withhold it in certain populations until we have more knowledge. And I think one of the reasons that the CDC is looking at a 8-week interval as opposed to a 4-week interval is it does appear to have less myocarditis risk. And to Hawkeye's earlier point, the reason we did a 4-week interval initially was because we were so afraid and we wanted to get people as immunized as rapidly as possible. But now the question is we have plenty of vaccines, so the story's changed a little bit. Now we want to get you immunized as well as possible. And what does that mean? That means you want to get the maximum benefit from the vaccine. It appears to be a little longer window, may be better. I bet that's where we end up. And I think we'll see fewer side effects once we get there, Hawk. That's my
Yeah.
guess.
It makes theoretic sense that, especially young people, that they have such an active immune system that the space between them to let their immune
Yeah.
system die down before the second re-challenge would be maybe end up in less myocarditis.
Yep.
Yep. And
Melissa-
to Dr. Beaver's earlier point, we know the risk of myocarditis with the infection for both young men and young women is much greater than any risk from the vaccine as well.
And do you still see myocarditis with Omicron too, Tim? I don't know as much about Omicron myocarditis.
I mean, it's so infrequent. It's not like we're seeing it a lot. So right, so hard to know. We're still seeing it, but it's not necessarily something that we're seeing it so much that I could tell you the difference between Delta and Omicron at this point.
Yeah.
So
And the risk of it, just to say there, to call it out, the risk of myocarditis with the vaccine isn't like 1 to 100,000. I mean, it's pretty low.
yeah, I think they parsed it out. You know, especially when you look at Israel, because they have such a robust vaccination program that they parsed it out in the age groups, and it obviously it was something I think in the highest age group, which I think was that teenage age group we were talking about, but it was still only 50 cases and like 1 million doses of vaccine. So
Yeah,
if you look
that's
at,
so
it's
many.
highest between 12 and 30, and that's even lower than that if you look at the whole group. So
I have a viewer who has a question about her daughter. Sal writes, my daughter had a cardiac ablation procedure to cure her SVT 3 years ago. She's vaccinated, but should I still worry if she would have a higher risk of myocarditis because of her previous health issues if she does eventually get COVID?
I don't think that there's anything about having a history of SVT or an ablation that's actually going to put her at higher risk for myocarditis. It's really a completely separate problem that, the procedure she had is a 95% generally curative procedure. And so there's no really relation between an SVT, that extra circuit that they made go away, and the risk of myocarditis for her.
Melissa wants to know about her husband. My husband has AFib. He was hospitalized from COVID before the vaccine was available. He's 3 months out from his booster. So is he supposed to get another one now, his booster early, or is it just the immunocompromised?
I'll just start. I would not consider this patient immunocompromised. If he's 3 months out from that booster, so to me that's going to be that third dose, he should still be fine. And then I'll let Dr. Beaver make any comments about the AFib itself, but I wouldn't see that as immunocompromised.
Okay.
Again, the AFib, I don't think there's a big relation between that and the COVID, although during the acute illness, obviously any illness can, if you have a history of AFib, can make you more likely to have more AFib, but I don't think the AFib relates to the risk of myocarditis, if that was part of the question.
I have a question for Dr. Stites. This is our last question for this morning, but we're going to save the ones that we haven't gotten to. Dr. Stites, this is from Angela. She writes, did Dr. Stites say a second booster should be given 3 to 4 months after the third?
Okay, so this is highly immunocompromised people, like organ transplants, active chemotherapy,
Right.
severe disease. You're on drugs to help suppress your immune system. Last Friday, the CDC put out some new guidelines, and they were saying, okay, look, so between you do your initial dose, then your next dose, right? A month apart, 3 or 4 weeks, depending on Pfizer or whatever. And then you do a third dose another month apart. And then your fourth dose had been 5 or 6 months, and now they shortened that to 3 months. So 4 doses essentially in about a 6-month time frame. That was in the CDC last Friday, but that was that's a narrow population and it's because people with really suppressed immune systems may not have as much of a response, and that's why if they get vaccinated, they have to have more doses to get their vaccine, to get their immune system really prepped, both for antibody and T cell immunity.
Want to get to our final thoughts from our guests. And again, if you have more questions, you can always keep them coming to us on Facebook and on YouTube and on the Morning Medical Update. We will answer them. Dr. Smith, I want to start with you. Final thoughts this morning.
Yeah, besides the fact I love watching sports and I'm a participant myself, sports and exercise is extremely important in adolescents for their emotional health, mental health, physical health. I wanted to get in this recent study, Journal of Athletic Training. There's a research group in Wisconsin that has been following the data since the pandemic started, and they have shown, they keep reporting this data, that the reduction in anxiety and depression in adolescents by sports participation is profound. And also the improvement in physical capacity and functional in the adolescents' health is so much better than in areas where they just shut down sports completely. So we've got to remember those things too. And as we produce these guidelines, it's not just to get people back on the field so we get to watch everybody play. We want to do that safely. It's always about the health and safety of the athlete. But we also want them to recognize there are potential risks. This myocarditis is a real thing. So we want them to be honest. Please be honest with your athletic trainers, your coaches, your parents, with your teammates. If we all want to play our sport, we've got to work together as a team. You saw that in the NFL. Prior to that, the MLB. We're prepared to start baseball again, we hope. And it's going to be ongoing. We're not done with this. I love Dr. Steitz's comments about when I hear him say, I think we're seeing a glimmer of hope, I listen to him because he's following this. He's followed it for 2 years. And these experts that I get to sit with, again, I'm humbled by that. And so let's get out and do things and not be fearful, not panic, but be really smart about it. And be able to talk about it. Learn from one another and be willing to talk and not get angry if it's not your opinion that's being followed. Learn from these experts. And again, I'm humbled and I appreciate being here today.
Dr. Beaver, final thoughts for you.
Yeah, I think it's important to understand that myocarditis is not only from the COVID virus or the COVID vaccine. I think it's very rare with both of those, but it's also happens with other viruses. So I think the important parts that Dr. Smith pointed out is we all want everybody to be back being active. The people I take care of, whether it be professional collegiate athletes or those people that in their adult life, which is the patients I mostly focus on, that follow that honesty with their doctor, follow infection control rules, follow masking rules to try to keep yourself active, because it doesn't just impact adolescents' life and their mental health, it impacts everybody's mental health. They are more productive and happier when they're active. So I think that it's important to extend that out to the community and everyone beyond the teenage years. But I think just as long as people understand what we said today and the importance of following these guidelines, I think we'll hopefully get to watch people play sports and be active ourselves and be a happier community as we continue to deal with this boat or this plane that we're in.
Dr. Hawkinson, you want to piggyback on that?
Yeah, I'll echo all of that. I think it is important, and we heard from Dr. Smith, talking about Dr. Steitz, and the numbers are going down. There is a glimmer of hope, but we still continue to want to do the right thing. Cases are going down, hospitalizations are going down. However, right now, it continues to be important to mask in those high-risk situations, and please get vaccinated and get up to date with that booster as well.
And Dr. Steitz, that's what you've been echoing all morning is, to take an Olympic reference, we don't want to get out over our skis on this.
Yeah, you don't, do you?
Yeah.
So first of all, thanks to our guests. Talk about being honored to be with smart guys. These are pretty good folks here. So that story I told you about the patient who got so sick after having had COVID-19, and I went to go by yesterday and things were a lot better. And they're better because we took the evidence that we've learned through COVID and we applied it and used therapies to help get her better, and she's a lot better. When we rest our thoughts in things that we know are true or in science, then our tomorrows can be shared with our families and friends. The problem is that when we decide to maybe ignore a lot of the data or not really understand it or try and take people away from the information who should be a part of it, like pharmacists, then you have to think about what will your tomorrow be like. If we build an entire medical system on whispers and rumors, how well will we perform? How many lives will we save? If we had given somebody something that didn't work, where would she be today? Versus doing the things that we know, that we've tried and we've learned. And there's no penalty, there shouldn't be a penalty for not knowing. People shouldn't criticize you early on while you're trying to explore and learn. But once you've learned facts and you understand what the science is around those, then you have to give up some of those preconceived notions and stay with the things that you know that make people better. And I think ultimately that's our job in medicine. Our job is to heal. And sometimes healing means we go to comfort measures and we let people die and people have to begin the next phase of that healing process. But most of the time we heal by offering therapies and offering hope. And hope is a powerful, powerful therapy. And it's one of the most important things we can ever offer. But you don't offer it by giving people false hope. That is no way to build a medical system. That's no way to build a future. Let's have as many tomorrows as we can. Let's do that by working together and having open, honest conversations and not screaming at each other. We have to remember the enemy is the virus. It's not each other.
Amen to that. Thank you, Dr. Stites, Dr. Smith, Dr. Hawkinson, Dr. Beaver. Thank you for joining us this morning. Remember, you can catch our shows anytime on Facebook and on YouTube. They live on in those forums. Also, coming up tomorrow right here, we have 18 hospital chief medical officers from across the region. They will be joining Dr. Stites, bringing us the latest trends in the COVID surge. And we will be answering questions from the news media and you, our viewers. We love your questions. Have a great Tuesday, and we will see you tomorrow at 8 a.m.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.